Hey everyone, I'm doing your tutoring a little different. I got a request from a classmate to go over the PowerPoint and point out the things that you absolutely need to know. So buckle up, get your note-taking apparatuses in the go position, and let's go. So the simple definition of cancer is overgrowth of cells or uncontrolled cell growth. Now, each cell in our body, when it's created, it is made with an expiration date, meaning the cell will grow to what it's supposed to be, and then eventually it will die automatically. Okay, this is a normal process in the body. The process is called the apoptosis, cell death, programmed cell death. Now, when cancer happens, the program is cut off, meaning the cell never dies. It could be because of chemical exposure, it can be because of viruses, illnesses, but something has damaged that program in the cell to where it doesn't turn off. So if it's not turning off, it's continued to grow. All right. When it becomes bad, it actually grows and it invades other cells, other organs, other body systems, and that's what we call metastasis. Now, there are many causes of cancer. Some of them are well known, like cigarette smoking, asbestos exposure, but there are other factors that should be considered. Predisposition and genetic factors. That means you have a liability or chance of developing this cancer because it runs in your family. One that comes to mind is breast cancer. Carcinogens and promoters. Carcinogens are those known substances that cause cancer. We know for a fact, we have the evidence to prove that the use or exposure to this chemical, such as nicotine, asbestos, and radon, causes cancer. A promoter is a substance or something that affects the body. When it comes in contact with a carcinogen or you use with a carcinogen, you will increase your chances of cancer. Now, in your textbook, it has alcohol on page 151, table 8.2, alcoholic beverages as a carcinogen, but then it later says that it's a promoter. Alcohol is associated with mouth, pharynx, larynx, esophageal, and liver cancer, so all with the GI. But it's not so much that it's a carcinogen in itself, it damages the tissue, and we know that repeat damage to tissue puts you at risk for cancer. Okay. As far as intrinsic factors, think of them as like those non-modifiable risk factors. So your age, we all know the risk of cancer increases with age. Your sex, not your gender, but your sex assigned at birth, so male or female, because we know that male and females, we have different types of cancer that we're more at risk for, and your race. Okay, all of those are intrinsic factors or those non-modifiables. You can't really change those. Far as diet, we know that obesity plays a part in the increasing your chances of cancer, mostly because of your risk for diabetes and all of the hormone changes that comes with the diabetes and the obesity. Dietary wise, what you eat makes a difference. Low fiber diets that don't include fruits and vegetables, you have a higher risk of having colorectal and colon cancers. Increase of red meats and a high fatty diet also puts you at risk for colorectal, pancreatic, and breast cancers. So what you eat does matter. And diseases, we know that diabetes is linked to breast cancer, mostly because the hormone changes, also to prostate, esophageal, and pancreatic cancer. But another disease that comes to mind is GERD. It actually puts you at risk for esophageal cancer. Just like alcohol, it damages those cells repeatedly, and that's what puts you at risk for the cancer. Now, cancer can occur in almost all tissues of the body, from skin, bone, blood, to actual organ tissues. In your ATI book, chapter 79, it explains the different names of the cancers based on the type of tissue which it originated. An example would be the epithelial tissues, those are your carcinomas, whereas your glandular organs are your adenocarcinomas. Okay? Now, as far as the actual different types of cancers, there's a ribbon for almost all types of cancers. Um, in your textbook, the Stromberg, which is the fifth edition, I want you guys to look at table 8.3. Okay? It's on page 156. And it's a really good one because it says major risk factors for the cancer. But this chart alone gives you a lot of good information. So for breast cancer, it has risk factors listed: history of breast cancer, yeah, history of some form of breast biopsy, close relatives with history of breast cancer, early menarche or you started your cycle early, or late menopause, you've never had any children, or your first child was after the age of 30, lengthy exposure to cyclic estrogen, those hormones, higher educational and social economic status, and consumption of alcohol. Okay? Now, why am I telling you all these? These risk factors are important for you to know. Why? Because they translate into client education. The best way to beat cancer is to prevent cancer. And how do we prevent cancer? Is through education, making clients aware of their risk and how to minimize those risks. You can't change the fact that your family has a history of breast cancer, but you can change your choice to consume alcohol, which we know is a cancer promoter. It gives you signs and symptoms. So for breast cancer, of course, a lump in the breast, nipple discharge, thickening or dimpling of the skin, nipple retraction, meaning instead of the nipple protruding, it's actually inward, pain or tenderness of the nipple. Now, breast cancer, we all know women, we're at risk, but men, they do have breast tissue. They may not have mammary glands, but they do have breast tissue and they can get breast cancer. It's very rare, but they can. So for the ones that's listed in this PowerPoint, the colorectal, the pancreatic, liver, all of those, I want you to go to that table 8.3 on page 156 in the fifth edition and look at those risk factors and those signs and symptoms, because those can translate into your assessment finding. You assess this patient and you notice this. What do you think is happening here? You're teaching a client how to perform screenings, and that's on table 8.4, the different types of screenings, when they need to go to the doctor, when they need to have imaging study, what type of at-home tests that they can do. Like women, we can do self-breast exams at home. Now, as far as the TNM staging, it's simple and we don't need to go too deep into it. So the whole purpose of it is to tell us how big the tumor is, if there are any nearby lymph nodes involved, and if the cancer or the tumor has metastasized to other areas of the body, affecting other organs. So the T is the actual tumor. Now, if you have T0, there's no evidence of a primary tumor, so there's no cancer. If there is a T1, 2, 3, or 4, the tumor is present, and the bigger the number, the bigger the tumor. Okay? Special one is TIS, or tumor in situ. That means it's encapsulated inside the site. For N, it's the node. Remember I told you the lymph nodes that are involved. NO, no involvement. But N1, 2, and 3 lets you know how many nodes are involved. And it lets us know how far the cancer is spread. Now, metastasis, MO, you guessed it, no metastasis, great. But if it's M1, 2, or 3, that lets us know how far away from the primary site the cancer has spread. As far as diagnosis, a lot goes into it. Categories of biopsy, radiography, endoscopy, and lab work. Biopsies is where we're literally going into the site of the cancer and pulling off live tissue to test it to see if it's benign or malignant. If it's benign, it is a tumor, but it's non-cancerous. If it's malignant, it is a tumor and it is cancerous. Far as your biopsies, you have different options of biopsies. You can have a surgical incision, or they go in, they make a surgical incision and cut out a small piece of the tumor. You can do aspiration. They literally put a needle inside and try to aspirate or suck out some of the cells of the tumor. And you can have like a brush biopsy where they go and just scrape a little bit of the tumor off. Okay. You do need to know the different types of the biopsies. And for your nursing implications, ATI has it listed short, sweet, and to the point. So for nursing actions, for any type of biopsy, you must obtain a signed informed consent from the client. And when I say obtain, the doctor obtains and you witness the consent. You ensure that the consent is on the chart before sending the patient for the biopsy. Assemble supplies that facilitate aseptic technique, prevent bleeding, withhold anticoagulants, which is important. If the patient is on an anticoagulant and we go and we introduce a needle into the body for a biopsy, we know they're going to bleed because we stuck them, right? We cut them and we stuck them. But they're at increase for hemorrhaging, major bleeding because of the anticoagulants. Biopsies, I've never seen a biopsy done emergently. So they're pretty much planned out. So you would need to know if the patient's on an anticoagulant so they can stop the medication at an appropriate time before the biopsy. Monitor for post-procedure bleeding. Usually we need to hold pressure at the site depending on where it is and monitor for external bleeding, but also those signs of internal bleeding. Okay. Provide a safe environment until effects of sedation are minimal. That's with any type of procedure that has sedation. We have to make sure that the patient's airway is protected and they can go back to the floor or general care or be discharged home once they can maintain their own airway. Ensure adequate oxygenation during the recovery period. Monitor vital signs for post-procedure protocol or as indicated. And position the client in a recovery position appropriate to the procedure. Okay. On the right side, following liver biopsy. Why do I need to lay on the right side after a liver biopsy? Because that's where the liver is, and we want to hold pressure so we don't bleed. The liver is very vasculature. So definitely know your nursing implications for your biopsies. When radiographies, those are pictures. We're trying to get an image of the tumor and the metastasis if it's there. So you can have CT scans, you can have MRI, PET scan. Anytime you hear imaging and cancer, you should think PET scan. Ultrasounds, x-rays. Women, mammograms. That's one of the imaging studies that can be done. As far as endoscopies, that's when we actually introduce a camera into the body to get a close-up look of what's going on. And depending on what top part of the body is being scoped, it'll tell us by the name. So an arthroscopy, they're going into a joint, make an incision, insert the camera, and they're looking around to see what's going on. A bronchoscopy, they're going into the lungs, into the bronchioles. A sigmoidoscopy, they're going into the sigmoid colon, trying to see if there are any polyps or is there any type of cancerous material. For lab work, I want you to know that you would see different changes in your CBC based on the different cancers. And the one highlighted in your text is the elevated WBC or your white blood count in the presence of leukemia. A specific cancer lab is your PSA, your prostate specific antigen, and that's to detect prostate cancer. I don't need you to go too deep in the specific antigens and everything else, but you should know what a PSA is. When it comes to treatment options, people are familiar with chemo. It can be oral in the form of pills or intravenous. Any form that is administered by the RN. And yes, there is a certification, an oncological certification for RNs to administer the different types of chemotherapy. What you need to know about chemotherapy are the complications of the chemotherapy, and we're going to get down to the oncological emergencies, but the non-emergent complications like the nausea, the hair loss, the fatigue, you do need to know the nursing care that is involved for the non-emergent side effects of chemotherapy. Radiation therapy, most people aren't too familiar with it, but what you need to know is the difference between external and internal. Whereas external, you can sustain radiation burn, so it's very important to keep up with the skincare during the radiation treatments. I want you to please look at the patient teaching box on page 166. It tells you how to care for the client, which in turn tells the client how to care for the client. One of the most important ones: limit cold and sun exposure. When outside, use sunscreen. Everybody should use sunscreen. Everybody should use sunscreen. Okay. With the SPF of at least 30, especially in the area of skin not being radiated. Radiation therapy makes the patient more susceptible to sunburn. It makes it very, very sensitive. They should use sunscreen. They should definitely wear long sleeves. Limit the time spent outside in the sun. Big brim hats, things like that. So definitely look at the skincare during radiation treatment. When it comes to internal radiation or brachytherapy, you have to know what type they're having. So it can be administered two different ways. It can be sealed, meaning it's like encapsulated in something and placed in the body at the site of the cancer, or it's unsealed and they can take that orally, or it can be injected into the body. Either way, it's radiation. And while they're under this therapy, they're emitting radiation. So it puts those who are caring for them at risk. Okay? So you want to limit the time that you're with the patient. And on page 167, box 8.4, it gives really good information of how, when you are at the bedside with the patient, what you should do. Like when you're doing your assessments and everything else, make sure that you're mindful of the time you're at the bedside. You want to spend no more than 30 minutes at a time at the bedside. So when you're there, you're working efficiently. Okay? Wear gloves when handling bedpans, bed linens, and the patient's clothing, any of the patient's bodily fluid. Normally, when a patient and inpatient in the hospital, they're going through this radiation, there's signage on the door letting you know when you come in that the patient is under radiation therapy. And they have the special gloves and all of the PPE outside of the room so you can put it on and you handle it. One of the things that people didn't really realize was important when flushing the commode. So if you're emptying a urinal or a bedpan and you go to flush, you empty it and then you have to cover the lid, the whole toilet, and then flush, because if you don't, it aerosolizes the radiation into the air, increasing your risk of exposure. Okay, let's talk about the oncological emergencies. For tumor lysis syndrome, although it's an oncological emergency, it's a good thing. We actually want to see the patient going through tumor lysis syndrome, because that means the chemo is working, because it is lysing or cutting up the tumor cell, which is what we want. But there are some undesired effects that happen once we slice open that tumor cell. So once it's lysed or destroyed, everything that was in that tumor cell is now in the bloodstream. So your potassium will go up, and I mean go up high. Your phosphate levels will go high, and your uric acid levels will go high. But your blood calcium level will go low. Now you have to have those four things: high potassium, high phos, high uric acid, and low blood calcium after chemo for it to be considered tumor lysis syndrome. So what would be the emergency here? That high potassium, because anytime our potassium is way high, we run the risk of having cardiac dysrhythmias. Okay. And uric acid, no, I didn't say the person had the gout, and I know everybody wants to talk about gout when I say uric acid, but this goes up because of the tumor cell being lysed. So with uric acid, what would be the treatment for high uric acid? Allopurinol. How do we treat the high potassium? We can give them medications to draw the potassium out, and it can be excreted in the bowels. We can give them insulin and dextrose to put the potassium back in the other cells. Okay. Far as the hypercalcemia of malignancy, this is more so because of the effect of the chemo on your bones themselves. It makes them weak and brittle and break down. And when bone is broken down, the calcium leaks into the bloodstream, increasing the calcium levels. And I'm not talking just a little bit. I'm talking more than 11. So calcium of more than 11 for someone receiving chemo, we can consider this hypercalcemia of malignancy, meaning the malignancy caused the hypercalcemia. Now, DIC I touched on when we did our hematological discussion, but DIC, or disseminated intravascular coagulation, is a two-part problem. It starts off as a clotting problem. All right. So the cancer is traumatic to the body. And so with that trauma, your body is releasing a lot of clots. All right. A lot of clots. They're not big clots, not like the things that you think of when I say PE. Think of micro clots. And micro clots can actually clog up all of the small vasculature, the capillary beds and the veins. All right. When this happens, they've used up all of the clotting factor. Now they have no more, so now they begin to bleed. That's why I say DIC is a twofold problem. You clot all that you're going to clot, and then you bleed because you used up all of your clotting factor. With that, anyone on chemo needs to be put on what type of precautions? Bleeding precautions. When we're assessing the patient, we need to look for signs and symptoms of decreased perfusion because those clots have blocked off blood flow. So sluggish capillary refill. Okay. Far as neutropenia, I need you to get this and remember this. Neutropenia is defined as an absolute neutrophil count less than 500. Okay. These infections are life-threatening and patients are hospitalized for IV antibiotics and antifungals. Anybody with an absolute neutrophil count less than 500, what type of precaution do they need to be put on? Neutropenic precaution, also called protective precautions, also calls reverse precautions. Okay? We're not trying to protect ourselves from the client. We're trying to protect the client from us. So no fresh fruits and vegetables. Please, no children. Okay? No flowers. They have to have their own dedicated equipment, and anyone providing care has to have PPEs when interacting with the client. Now, spinal cord compression and superior vena cava syndrome, I don't want you guys focusing too much on that, but what it is, the cancer has metastasized and it's grown to where it's compressing on the spinal cord, and you'll see signs and symptoms of like lower extremity weakness or weakness below the site of the spine. You'll have the patient reporting back pain, new back pain without injury or cause. And for superior vena cava, it's the same thing. It's pushing down on the superior vena cava. So we're having blood restriction problems where you'll see where the person is having edema, especially around the neck and around the face. What you really need to focus on, tumor lysis syndrome, the hypercalcemia, the DIC, and the neutropenia. Death and dying is a major part of nursing. We care for patients at both ends of the spectrum when they come into life and at the end of their life. And it takes a quality that can't really be taught, one of compassion and caring, to take care of the needs of the family member, whether that's the family as a unit. And an example, if you have someone who's on hospice, the client who's actually on hospice is the main patient, but the caregivers are the ones who love them, especially the ones who are directly involved in their care or live close to them. They're considered the patient as well. And it helps to know not only the anatomy and physiology of dying, but it also helps to deal with the emotional and the mental part that comes with dying. And Kubler-Ross, she wrote a book, the book's older than I am, 1969, on death and dying. And she researched and found out that everyone who grieves tend to go through these 5 stages at some point. Not everyone goes through every stage as it is. Some people jump around, some people start at the first and go all the way to the last. But as a nurse, you need to be aware of the 5 stages. Denial, anger, bargaining, depression, and acceptance. Knowing these stages will help you provide better care to whom it may be, whether it's the person who's actively dying, the patient who just got a terminal cancer diagnosis, or the mother of a child who is passed. You need to know these. It's a video attached to this. It's satire. It's more funny than anything, but it really drives home the 5 stages of grief. And remember, people can go through all 5. Some people jump around, and some people actually follow it: denial, anger, bargaining, depression, and acceptance. And I want you guys to think of something, a major loss, whether you were fired from a job, you lost a loved one, you lost a pet. And think about how you went through. Did you go through all 5 of these, or did you skip around? Now, as far as palliative care is different from hospice care. Palliative is to treat the symptoms. We're trying to make them comfortable. It's not going to cure any of the terminal diseases or illness. It's not going to prolong life, but it will keep them comfortable. So think of pain management. Anticipatory guidance, we know the trajectory of the dying process, so it helps us to be able to, I don't want to say counsel, but to advocate for the client, communicate with the client's family members, and educate them on what's going on. Pain is still a big issue in the dying process, and this is when your pain scales come into play. We all know the numeric, but that's only working for someone who's conscious, cognitive, and can actually use it. In the death and dying, at some point, they actually become unresponsive. Excuse me. But they are still experiencing pain. Well, Ms. A, how do I know they're experiencing pain if they're not telling me they're in pain? You have to look at the physiological symptoms, the grimacing, the groaning, the agitation, okay? Dyspnea is another major thing that we have to control in the palliative care and the death and dying process. Morphine, we know morphine is for pain, but morphine can actually help with air hunger towards the end of life. And delirium, as the body starts to get closer to death, there's less perfusion. So there's less perfusion to the brain. So there is some delirium. You may have people calling out for dead loved ones. What I've seen, elderly patients actively dying, calling for their parents. It can be disturbing to a non-healthcare worker to witness and experience their family member going through this. So this is when your compassion kicks in, and you very, very, very kindly explain to them what's happening to them, and just be there for support, therapeutic communication. Let them express to you how they're feeling witnessing their loved one pass.